Hey guys, it's me, that brown nurse. I want to be talking to you about my experience in my 3 years as a pediatric student nurse and the placements I've had, starting from placement number 1. This was the pediatric ward setting. Now, it's all about infants, child, preteens, and adolescents aged 1 month to about 16, 17, depending on the complexity of the care. Now, generally, what I saw on my first day as a pediatric student nurse is I was assigned with a mentor, and this mentor was working or allocated to the high dependency unit. So I got to witness high dependency care on my first day, and this was the most amazing but tiring day of my life, because it was my mentor going through everything in the start of the shifts really quickly. It was the winter when we started this course, so we were sent out on placements in, like, I think November time or something, or October time. I don't remember from the top of my head, but we were sent out, and literally like babies swarmed on this winter outbreaks of flu, bronchiolitis, RSV, you name it. And even the adult wards were, I think, really packed and filled. So I was taught the normal things: checking oxygen suction, doing your safety checks, observations. I was shown the observations chart. She was teaching me whilst caring for patients on the go. And it was something that always intrigued me, how nurses can multitask. On my first day, I was like, I can't do this. I am not ready for this course. You know what? I feel like I'm about to quit. However, as the hours went by, I got to around 3 p.m. Started my shift at 7:30. It was meant to finish at 8:30. It went to 3 p.m. This patient was on hourly observations. Overall, the condition was fine, but she was just on the high dependency unit for a medical condition that did deteriorate in the past. But that day it was, settling or stabilizing and stuff. And I got to have a chat with this patient. She was about 6, 7 years old or something. And she was so distressed, and I was like, hey, listen, hold my hand and I'll put this blood pressure cuff on you and stuff. So I was already, instilling that great level of patient care, or patient-centered care and family-centered care, because the mom and dad was present, and when they were present, I was trying to reassure them, and saying how, like, well, there's how, like, lovely this child is. Like, she's, look, oh my god, like, you're trying to make some communication where you're making them laugh, and even though it's a high intense environment or something, you're making them feel reassured and not feel like they're in hospital kind of thing, because you do want to stay professional, but you want to have that good report and good therapeutic report. This is what I got taught. Always have a level of professionalism, but make sure you're not talking to your patients like a robot, because if you do that, things do not go well, and that's when complaints start arising and stuff. But thankfully, I don't think I've had one complaint over my 3 years, and that was for talking. It was my first ever night shift, and I forgot that night shift you're meant to be talking like calmly and everyone's asleep. I'm there in the corridor saying, hello, can you... I was speaking to a colleague, and it was, I think one of the parents came out and he's like, please could you like decrease your volume? So I had to decrease my volume, and I wasn't used to night shift, so I didn't know the expectations and stuff. But yeah, that kind of, when you get a parent telling you something, you learn from it. When you get an assessor telling you something, you learn from it. When you get a colleague telling you something, you learn from it. Now, what happens most of the time is people don't learn from it. They sit in the corner and cry, and they quit the course. This is one thing that I did on my first, like I said, I did want to quit because of how high dependent this unit was for pediatrics, and the whole cubicles were like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and it was like a beeping. The IV pumps were beeping. It was so overstimulating. However, my assessor I worked with, she reassured me, she educated me so much. I loved it, and the parents were so lovely that I worked with that day. They made me want to bloody do more shifts that week. But it was amazing, let me tell you, because you learn about sepsis, you learn about how the pediatric unit works, and you learned about asthma, exacerbations, RSV, bronchiolitis. Like I said, it was winter, so all these things were occurring, and you learned about pediatric oncology. You learned about poison ingestion, seizures and disorders, um, and DKAs, which also arise in the unit. So many things were happening in that week, and it's like the things that mattered the most to me was the size of the cuffs. So you have different sizes of pediatric cuffs, and I forgot, like there's a small size 3, or like a blue, light blue cuff, and there's like an orange cuff for babies, and then there's like a big gray cuff for like if you have a bigger arm, like for example mine. To be honest, my arm's not that big, but if you have a patient that's got the same circumference of my arm, yes. And we make sure that they don't feel like we're over medicalizing everything. As a student nurse, my job was on that day to learn, observe, and communicate, which I did. Now moving on, that was my first placement. I had 6 weeks, I think, in that placement. 6 weeks. It was one of the best placements I did in that year. Pediatrics ward, general ward, 12-hour shifts, way to go. I also did after that a palliative care hospice, and this one made me rethink about everything, and it made me so grateful because I had family members that received palliative care in their childhood, and I saw that in hospital. They received it in hospital. I don't think I saw them ever visit a hospice or do respite in the hospice, but it was in the hospital setting, and I felt like I was kind of reminded by it again, like wow, like this palliative care is ongoing nationwide, and it's so amazing what these nurses do and these healthcare assistants do and these volunteers do. Because as I said, as a student nurse, your job isn't just to work with the nurses, you're working with a whole wide multidisciplinary team. So making sure you have a good communication with everyone in that workplace, even the cleaners, because the cleaners, the housekeepers, you just have to smile, say hello, introduce yourself, and make sure that you're showing that you're passionate about your job and your role as a student nurse. Now, in palliative care placement, it was emotional because I got to see lots of children with complex needs, and also try to communicate with their moms, and sometimes when they were getting new admissions in this hospice, the parents would be quite scared, nervous, and honestly, as a parent, well, I'm not a parent, but if I was a parent also, taking my child to a new setting, I would be the same. So putting yourself in someone else's shoes is also another thing that you need to learn in nursing if you're a student nurse watching this. And yeah, you learn about in palliative care, you actually learn about how children are cared for. They might have heart, congenital defects. They might have long-term conditions. They might have complex genetic conditions, metabolic disorders. All this stuff you're witnessing and you're learning in your first year. You're speaking, you're interacting, you're building on your non-clinical knowledge and also clinical knowledge, because you want to do your medications calculations. You want to learn about tracheostomies, stoma care. You want to learn about all the different aspects of care that is provided to these children. And by only doing so, you're making yourself a better student nurse by actually reading outside of the placement, doing the research outside of the placement. And that being said, my assessor was so amazing in that placement. They supported me, and yeah, that was also one of my best placements. After that, I had pediatric day case setting. Now, day case was actually quite chilled out, quite cushy. It was like a Monday to Friday, 7 to 3, 7 to 5 kind of thing, and it was amazing. So you had I think 1 day off or 2 days off in that week. So you're only going in 3 days a week or 4 days a week. I would have to check my timesheets, but it was amazing because they're coming in for general anesthesia or local anesthesia, and what you're doing is you're getting their weight, you're getting their height, you're kind of admitting them. And I got to do lots of non-clinical documenting skills and putting them on the system, how the hospital systems work, which was quite amazing to see as well, and how the nurses balance with so many caseloads of theatre checklists and then surgeons coming in, anesthesias coming in. You're all trying to communicate what time this patient needs to go down to theatre. It was quite nice. And taking them to theatre, like actually the worst part was taking them down to theatre because the mom or dad, they would start crying, and I'm standing there like with my hand on their shoulder, you know, giving them reassurance, giving them like, oh my God, it's gonna be fine. Please, please, your child is gonna be fine. Stay strong. You're giving them that extra bit of compassion. We already have compassion, but I feel like in their case, what I built on my compassionate skills from the palliative care placement, it kind of carried on or developed more strongly onto the day case setting, because it's like you're seeing more parents each day crying when the child goes down under the general anesthesia, and it's really emotional. It's really distressing, and I found that to be quite sad. But as the child recovers and they go home, which is the best part, they go home safe and sound, and you're working with amazing nurses as well in the daycare setting. So this is something you should also, if you haven't done this, you should do it, and you can get to watch down the operations. I got to spend a day with a dentist and watch dental procedures being done, which was amazing. After that, now let me think. Let me think. Welcome to my second year. Now, in my second year, I'm about to tell you the second year placements I had. So in second year, I had neonatal intensive care, and this was for 5 weeks or 6 weeks also. And this placement, I was like, what is going on? What is going on? Have I entered the world of babies, non-stop crying babies? Which I did. So my first day it was great. It was great. But at the same time, I was overwhelmed with the high sensory environment where you're having the ventilators beeping in the other room, and you can hear it from 6 rooms down, and you're having that rushed. It's like a rushed environment, because although it's neonatal intensive care, you think that babies are quite chilled out. Well, let me tell you something. The babies that are in the neonatal intensive care are, neonates. It's in the name. So they're from 0 to 28 days, and they can start to be admitted from, I think, 22 weeks or 23 weeks. But I've not seen any 22, 23 weekers. But the minimum, the smallest I've seen is like 24 or 25 weeker, I think. And they're so small. They're so small. The incubator has to be on. The humidity's got to be on. The incubators are wet, foggy, and misty. And they're all trying to represent the womb, because the baby has not fully developed yet. So the baby still thinks it's inside the womb. So we're trying to make that setting. And don't get me started on the observation measurements. Compared from pediatrics to neonatal observations, like the blood pressure measurements, I saw it on my second or first day. The nurse was showing me, and I was like, what? A blood pressure of 20? What? Am I seeing this? Yeah, but so my first week was trying to get used to the basics of neonatal intensive care unit, which I did. Second week, I started to build on my communication skills, build on my handling techniques with babies, kind of doing the nappies, in and out. I was being quite fast, making sure I'm looking at the list and using my initiative, which I also developed. And this neonatal talk is going to be moving on to the next part of the video too, so stay there. I think also what I like about neonates is they have different rooms. So they have special care, which is where all the babies go, and babies that are about to go home kind of thing go. And then they have the high dependency, which they call the teddy bear room. So high dependency 1, and then there's like different high dependency 2s, and I think you can have a high dependency 3 as well, depending where you're working. Now, then they have the intensive care rooms. So I've been in all these rooms, and let me tell you, I loved the high dependency room and the intensive care, because you're doing hourly to hourly kind of observations. I like the nursery too, because the babies are so cute and they're ready to go home. That's the best part of the job, is sending people home, because there's nothing much greater than seeing a mom and father excited to go home, welcome their child or baby in all arms to their extended family members. So I think that's the best thing too. And the nursery, you get to do a lot of bottle feeding kind of thing, cuddling. So I like the nursery too, but in terms of like clinical pace, the high dependency and the intensive care, you have the hourly rate and you're going, which is quite good. And there's so much more to see, I think, in the other rooms I mentioned. But yeah, this was it. I liked it. I liked neonates too. In my second year, this is my first placement, and working out medication calculations, all the doses are like super small compared to pediatrics. So you gotta have. There's gonna be that shock where you're like, whoa, am I doing something wrong or right? But you're always having a nurse working with you and everything to supervise. And as a student, you're supernumerary. Now, my second placement in my second year was the pediatric assessment unit. This was similar to first year in the ward. However, now in second year, you're doing stuff, you're initiating, and you're challenging yourself to push, learn more skills, learn more knowledges, and you're getting more sign-offs to do. So this was one of the most craziest placements because it was a 9-week placement, and on my first day, I saw like 25 different conditions coming in the assessment unit, which was quite amazing. One of the most which I enjoyed working with was wait. So my second placement was the pediatric assessment unit. Now this was a 9-week placement, and it was crazy. Let me tell you, it was crazy. I saw so many different conditions that I've never ceased to have synced that they exist in real life. Now, you're seeing patients coming in either from A&E, they get swarmed up from A&E, or they get streamlined from the urgent care center. So you can have a child with a McDonald's chip in their ear coming in, and that child is going to be seen by the ENT. Or you can have a child coming in with asthma exacerbations, a respiratory rate of like 75 and a heart rate of like 180 and blood pressure above or below the roof. And their respiratory working rate is like moderate or, extremely crazy. And that's what I mean. You can see a range of conditions and you're all trying to manage your workload. And you're working with a team of different specialties and different nurses and different doctors each day. So people have differences in opinion and you have to balance that. But as a student nurse, you're not there to, say to this person, hey, that's wrong, this is right. You're there to challenge bad decisions and help make good decisions. But you're not there to act like the boss, because there's no one the boss. In the assessment unit, everyone is their own boss because you're all tackling a certain thing, whether it's fixing the computer that's broken or whether it's trying to get messages from the admin, but then you're a student nurse and you're like, speak to the other nurse. Like, there's so many things that's happening, and it gets to about 2 or 3 p.m. I'd say, and the admissions and the non-stop referrals they get, it's crazy. And you're trying to set up bed spaces. You're working with like the senior nurses, and then you're working with the normal band 5 nurses. It's crazy. And you can even see babies on the assessment unit, actually, let me tell you, coming in with jaundice or coming with I don't know, breathing problems as well. It's a madness. However, on the assessment unit, I learned to, escalate always, document always, and making sure that I would ask questions when necessary. And I would stand up to the doctors and ask them questions on why they did this a certain way and why did that doctor do that a certain way. And it's all about the way you, portray yourself. If you portray yourself in a humiliating manner where you're like shouting and what's happened and all this stuff, it's crazy. Don't do that. Be gentle, be polite, and make sure you come across as a humble person who is respectable of their environment and their colleagues. And you are gonna impress a lot of people, I must say. When you're patient, you're gonna impress a lot of people. when you're hasteful and you're interrupting people, then that's gonna create problems. Don't do that, because I've seen that, and I've seen that happen with actually staff nurses that do it, and the doctors are like, "Hey, excuse me, why are you speaking to me like that?" Then I've seen that with student nurses asking the senior nurses stuff, and the way they, I don't know, the way the communication methods are, they need to be fixed up for some of y'all. But anyways, that was it. I'm gonna move on to my third placement in my second year, which is the A&E assessment. A&E assessment, or the accident and emergency unit. This was a 6-week placement, and I honestly, I loved it, because it was just literally a link between the pediatric assessment unit and the A&E, because you're going up to transfer patients, you're doing handovers, and you're getting them checked definitely by the nurses before you write something that's not even meant to be on there. So you've got that, backup protection as well. And it's A&E, anything can happen. At one time, you can be sitting, drinking your coffee or eating your yogurt, and then boom, the EMT team walks in with a patient on a stretcher, and you're like, I need to drop everything now. And as a student nurse, my job was to make sure that the nurses were supported around me. I wasn't there as part of the team staffing numbers, but I made sure that everyone was happy with their own bit, and I made sure as a student I was happy with what I was doing, and that I was competent and I was working within my boundaries. Because if I wasn't, then that's a big risk to patients and staff. So that's one thing I was scared of, working with outside my boundaries in an A&E setting. However, the team in A&E is so supportive. I love that placement as well because of the rush, and I still work there sometimes as a healthcare assistant, or if you're in America watching this, CNA. So you're just helping the nurses do observations, helping them, hold a patient's arm if they're gonna have a cannula, helping them, clean bed spaces, helping them offer drinks to patients, helping the doctors. Yeah, it's quite good, and you feel like the shift goes quite fast as well. It's similar to neonatal intensive care because it's intensive care, and A&E is like not intensive care, but it's care which is intense in the streamlining of the flow of the patients coming in and out. That's what I mean from that perspective. But yeah, A&E I loved. I did so many different procedures. I saw so many different procedures. I got to witness a helicopter coming down. A patient that needed resus came in, and I saw like the adult nurses and all these adult team going in and helping, because they share the whole resuscitation bay with the adult nurses. So it's quite interesting to, if you've not done A&E placement, do a spoke there. You will maybe find it interesting, and actually you might want to even work there as a future student, as a future qualified nurse. So that was something I really liked, and I encourage you all to, all the placements I've talked about, I encourage you to do them all, because you know what, I loved every one of them. And I can't, well, if I was to choose one that I loved the best, it was the palliative care, because that is not even a nursing placement. It was something so crazy, so amazing, so interesting, because you're working with complex children, right? And they have the technology they use to communicate. They have the eye gauze, so they can look at this iPad and can type kind of thing without speaking. And it's so amazing. It makes you feel grateful and humble. And their parents, the connections that you have a good connection with parents. Honestly, it made my day working with these children who are, their class is vulnerable as well, but you're having that emotional aspect of happiness, giving your happiness also, and then when they're laughing, it's the best thing ever. Like if you make a child laugh in a palliative care environment, although it wasn't like, people think of palliative care being sad. It's not sad. It's some moments that can be sad, and it is made to be for a like palliative care setting where a dying patient can have their last breath in that space, or in a palliative care hospice. However, I didn't see any deaths on my placement, and I felt like all the staff, all the team worked so well, and they were super nice. So thank you so much if you're watching this. and it's great. Welcome back to my third year now, and this is when I had the community placement. In community, you go from going into an office, you know, doing your jobs, looking at the list, looking at the referrals you've got from the pediatric ward. So that's I felt like I've got all placements kind of linked to each other, and it's amazing how pediatric care works in this nation. And I want to say, so you go inside, you put your lunch bag in the fridge, you put your bag on the side, you sit at the computer desk, and then you get like a nursing handover, kind of like a huddle. So you've got the manager there, you've got all the other nurses there, and they talk about who's going to which allocation, who's going to which house, and what certain procedures. Because if you have a newly qualified there and they want to flush a Hickman's line or a central CBC, they will not send a newly qualified nurse to do that, because it's quite scary to do, and you need a lot of training and practice, and you need to finish some courses to do that as well. So when I think I went to the nurse who was band 5, I went to a few houses, and she got to place gastrostomies in, and I got to learn how they fill the balloon up and do all that stuff. It was quite nice to watch and learn and also do. And the parents were lovely. Like all the houses I went to, the parents were so lovely and kind and welcoming. So community care is something that's unrecognized sometimes, but now what the whole mission is in the United Kingdom is to push hospital care into the community. So that is gonna, make some managers a bit, oops, like, wow, we got a full caseload of patients here now that we need to look after, and maybe they need more staffing now as well, I think, in community care. However, my time as a student nurse, I loved it. I saw many different, conditions, many different complex patients that also go on the ward to get admitted for, when they have deterioration, crises. And another thing is, I felt like community care and all my other placements was very different. In community nursing, you're kind of working, well, I'm not the nurse going in there alone, but it's lone working. And I asked this question to many people. I was like, what happens if an emergency happens? What are you doing? And there's no like emergency buzzer to pull. So the answers I got was they're gonna ring the emergency hotline services, which is the 999 in the UK, and what's gonna happen is they're gonna say the emergency, and that EMT is going to come, so ambulance or paramedics or police or firefighters, and they will come and help that case, whatever's going on, whichever emergency. If a child is, literally not breathing and they've tried CPR and everything, whilst they're doing the CPR and stuff, you go through your A2E assessment, you go through your red flag, and you ring the 999 and you say, hey, I'm in 21 Zoo Lane, please can you come to this location? I'm a nurse in community, and there's a patient who's in front of me. We're doing CPR breaths and we're doing everything we can. Please can you come ASAP and send an ambulance? Now, that would happen, of course. And if they see any safeguarding concerns in the house, they also send the police as well, just to cover everything up. Now, what I liked about community care was, like, you got to choose your allocations, whether you can be in the office, kind of speaking to parents and getting advice, not getting advice, kind of giving advice, but from the nurses. You're taking that knowledge and you're like communicating with family, and that's also helping improve your confidence, improving your communication skills. And this, I think, I love doing, because I had the guidelines up in front of me, I had the nurses out with me. I was like, this mom wants this. I was like, what should I do? So they helped me like kind of go through what needs to be said, and I was saying it, and it was making me so confident in speaking to these parents, and also giving them that reassurance. If you do feel like your child is having X, Y, Z symptoms, making sure that you go to the local assessment unit or ring 99 and stuff. It was amazing. Or we went out that same day to assess the child. for example, leaking gastrostomy or gastrostomy that had query infection or something. We were attending that house and making sure everything was okay on the same day if there was no like busyness on the caseload. I also worked with the managers in terms of doing allocations of who's going where. It was quite nice, and I even went on to like community visits with the manager, which was quite nice because I got to like speak about my time in placement, and having that one-to-one feedback is amazing. But I like community, it's quite nice, and it's something I'm seeing myself do in the future once I get my hands around the basics of nursing. So it is something nice, and I would do this. Now let's move on. Now what I had next was, guess what? Neonatal intensive care. And this is my 12-week placement. 12-week placement I did. I'm currently undergoing, and it's honestly amazing, because I had this in second year, and I know about the lore of the lore of this place now. I know about the basics kind of thing. I know like the blood pressure should be above the gestation, not too high and not too like low, and I know about what their normal ranges for observation should be and what the limits should be on the alarms, and I knew the stuff, so it kind of like gelled in well now in third year, where you have that knowledge and you have that base of clinical skills. You're just going to build up upon it and work within your competence, within your boundaries, but you're becoming a nurse now. So this is the final placement. So what I liked was I'm getting to have my own patient caseloads, working with families, communicating with families, documenting everything, doing handovers, which is the best part as well. And yeah, this is something I loved. And drawing up antibiotics is something I'm so bad at. Like, one point I asked my assessor, am I going too slow at this? And she was like, nah, you're good. But I feel like this is something I need to practice on, drawing up medications. And because sometimes there's like an air bubble and you're like pulling it back and you're pulling it up. And with me, I got a thing where I need to do this properly. I can't just say, oh wait, I've done it, but I have to do it properly. I mean, everyone has to do it properly in nursing, otherwise things go wrong and shit can hit the fan. So neonates, what's the differences between pediatric and neonatal care? Now, I think in terms of emotional challenges, you can deal with pediatric child abuse cases, non-compliance in teens, and grieving families. Now, this is pediatrics. In terms of neonates, you can deal with managing or working alongside these senior nurses in dealing with these, for these tiny babies. You're advocating, looking at different ethical considerations, supporting the parents throughout their prolonged stays in the neonatal intensive care environment, liaising with like social cares and liaising with X, Y, and Z safeguarding team. So this was something that on this placement I've seen a lot of common safeguarding cases with these families, and getting to work with them and stuff. It's something that also opens your eyes as a student nurse. Like, you gotta have this quick, it's like the spider sense. You gotta have that sense where if you sense something's wrong, always document, escalate it, because you never know what's behind this picture you're seeing in front of you and what's behind the picture you're seeing on the backside when parents go home and stuff. So always documenting small things, because it can make a big difference. Now, in terms of the family-centered care, we have pediatrics where you're doing family-centered care, you're kind of caring for the family, the siblings as well, alongside the child. And in neonatal, it's like family integrated care, where you're making sure the family is getting involved in that care with the child. Not just care planning, but care giving. So we're making sure they're doing the NG feeds. We're not making sure, but if they're comfortable and competent, they want to do, we're making sure to encourage these parents to feed their feed their tubes, feed their child via an nasogastric tube, doing the nappies, doing the cares. I worked with a mom in my second year. She was honestly anxious, so anxious to do a nappy for her baby. And I was like, I'm also anxious too, but It's your child, it's your baby. Please, let's. I want this baby because I know this baby is gonna be proud of you, mom. Like giving them reinforcement of short reassurance bursts and making sure to build these parents' courage up and confidence up. Because as a student nurse, it's in neonatal intensive care, I've noticed that you're dealing with a high anxious moments of parents asking questions that you may not know the answer to, but you have to always escalate this, and you have a lot of senior members around you, so letting them know that I may not be able to answer your questions, but I'm going to ask the rest of the staff here to help you get your answers. And what else was I going to say? Something like, now, in terms of using the equipment, we have the standardized IV pumps, and these are like the pediatric size blood pressure cuffs and pulse oximeters, oxygen masks, cannulas, pediatric research trolleys, distraction toys. This is all for pediatrics, right? Now, when we compare this to neonates, we have incubators, we have the CPAP, we have the umbilical lines, UAC, CVC, UVC, phototherapy lights, we have the micro infusion pumps, we have all sorts, we have the cooling machines, and the life starts and Lisa. It's honestly crazy. And the conditions wise, you will see, like I said, type 1 diabetes, DKA, type 2, RSV, bronchiolitis, asthma, sepsis. And neonates, you can also see sepsis. But this can be also coming with respiratory distress syndrome, necrotizing enterocolitis, congenital heart defects, neonatal abstinence syndrome, which is like when they're trying to withdraw from the drugs that the mom took. So they need, I think they need morphine. Yeah, they need morphine to kind of heal that feeling of wanting the drug. And we're trying to, like, calm this baby down, and you can hear a high-pitched cry, irritability, and you can also see sepsis in neonates, like I mentioned. So all the red flags you should look out for pediatrics, you should also look out for a baby in neonates. And in terms of the population I mentioned earlier on, but all I want to say is these are all my placements, and I'm gonna be closing the video because it's been a while now. It's very late, it's literally midnight, and I want to say thank you so much for watching this video, and I appreciate every one of you that's watching this. Please give it a like and share.